Well, welcome back. We're going to talk a little bit about one of our favorite subjects today, which is called oxygenation. One of the things we're going to do is we're going to get into some more formulas so that we can determine how well our oxygenation is actually going. So we talk about oxygenation. Remember, it belongs to PaO2. There are several things that we can use to increase it. One is FiO2, CPAP, BiPAP, PEEP, or mean airway pressure. Because oxygenation can be caused by a number of different things, we're going to talk about those shortly, then we have to have some way of knowing what is actually affecting it. And because of this, we have a lot of different formulas that we can apply in different ways that we can evaluate the patients so we can see what we can do. It's important when we talk about VQ mismatches to understand that if I give you oxygen, I should increase your oxygen level or oxygen status for you. If I give you oxygen and it doesn't improve, then the most likely cause is probably a shunt. When we have a shunt, we need to use what we call alveolar recruitment in order to open up the alveoli to allow the oxygen exchange to occur. And so we have to use things like CPAP, PEEP, BiPAP, something along that line. And when we do it, it does open up the alveoli. And when we do that, it increases the compliance and decreases the work of breathing for those patients. So some terminology to go with this. One is dead space. You guys remember dead space is ventilation without perfusion. The last third you inhale is dead space. The first third you exhale is dead space. Okay? A VQ mismatch. A VQ mismatch is on both sides of center, okay? I can have more ventilation with less perfusion, or I can have less ventilation with more perfusion. So I'm either on the dead space side of the house headed for dead space, or I'm on the shunt side of the house headed for a shunt. And there we see with our shunts, more severe hypoxemia. We're not getting the gas exchange we need. We're seeing the increased work of breathing. We're seeing hypoxia to go with it. So we're having a lot of problems with possibly cyanosis and things along that line. Remember, everybody has an anatomical shunt that's approximately 2 to 5%. And these are your Vespasian veins, your pulmonary bronchial veins. It's just, life, or fortunately for us, because we're used to it. When we talk about shunts, though, we always need to talk about 100% oxygen. If it's less than 100% oxygen, it's called a venous admixture. And that way, we're not going to be able to determine what the shunt is and how it needs to be fixed at that particular point in time. Physiological dead space, mentioned before in the last PowerPoint, it is your anatomic and your alveolar dead space. In some cases, we also throw in mechanical dead space. And this is dead space caused by the artificial airways, your ventilator circuits, your BiPAP circuits, your CPAP circuits also. A lot of times, though, just when you get these questions, they may just tell you it's anatomical alveolar, and you just let it go at that particular point. I'm going to give you some questions on this so you have an understanding of it. If you remember, we talked about being two types of respiratory failure that we address, and they are the hypoxemic respiratory failure and the hypercapnic or ventilatory respiratory failure. And because it's respiratory failure, remember it's not a disease, it's a process. And we need to know what is the underlying cause of what's going on at this particular point in time. If you notice, we have 6 major causes listed here. If we start at the bottom, you have decreased inspired oxygen. We see this with our patients who have COPD. We see it with patients who are ascending higher in the altitude. Remember, people who do mountain climbing, as they approach the summit of the mountains, they have to slow down. Sometimes they have to take oxygen with them to be able to use it because of the problems that they have with it. Perfusion diffusion impairment, we don't see that much of it. Diffusion impairment, we can. If you think about a time when you had a really bad cold or something along that line, and you were having difficulty breathing, you had some extra secretions you were coughing out, that's a diffusion impairment. That's an example of one, okay? The other three, VQ mismatch, shunt, and alveolar hypoventilation, are the major causes we're going to go ahead and name as our causes of acute hypoxemic respiratory failure, okay? These are the big three. The other ones do apply if they're bad enough, but these are the three that are really going to cause us problems. Remember again, a VQ mismatch can be ventilation with decreased perfusion or decreased ventilation with perfusion. A shunt is perfusion without ventilation, the opposite of dead space. Alveolar hypoventilation is one of those ones that really sometimes crosses both lines between hypoxemic and ventilatory or hypercapnic, because you have two things going on. If you remember the definition of hypoventilation, that means very slow down breathing. And as a result of that, your CO2 is starting to increase and your PaO2 is going down, okay? And we can see that sometimes with our patients after surgery. We can see it after, just even a mild procedure in some cases. Patients who aren't moving around a lot can also have these problems. And so we need to know what is the underlying reason for that. A venous admixture will also affect this, as we just talked about on the previous slide. This is whenever your patient's on an FiO2 less than 100%, and we have a lot of venous blood at that particular point. So the question basically is it a VQ mismatch or a shunt? We can tell alveolar hypoventilation just by looking at the patient. If you're in there and you're counting the respiration and it's 6, that is alveolar hypoventilation, okay? And we're going to take a look at that a little bit more here shortly. So for the VQ mismatch or the shunt, we're going to look at our different formulas. We're also going to look at the ABG, okay? With both a VQ mismatch and a shunt, we have a decrease in our PaO2. And we have that decrease in that PaO2 because of poor gas exchange. However, this PaCO2 can either be normal or decreased. It depends on what's going on with them at that point. But we will see an increase in our A to A gradient, okay? And I'm going to tell you there's a new term in town for A to A gradient. It's called the A to A difference, the alveolar arterial difference. And if you think about it, that's pretty descriptive because we're looking at the difference between the amount of alveolar oxygen that's available and the amount in the arteries at this particular point. Because we're having a poor gas exchange, that's going to get larger and larger and larger. With alveolar hypoventilation, what we see is a decrease in our PaO2, increase in CO2. However, the A to A gradient or difference is normal. And it's normal because the problem is you don't have gas exchange going on. And you don't have the gas exchange basically because the patient's not breathing. So this is a little table I found some time ago, and basically it shows you with a shunt VQ mismatch alveolar hypoventilation that PaO2 is going down. However, with a shunt and a VQ mismatch, the PaCO2 can be normal or decreased, but it's always going to increase with alveolar hypoventilation. And then the A to A gradient or difference is going to be increased with a shunt and a VQ mismatch. It remains normal with alveolar hypoventilation. So one of the things I want to stress at this particular point in time is good patient assessment. It's a skill that you have to practice, and you have to continually practice. When you get to start working in a hospital, this is your chance to really learn your assessment techniques. You've had the opportunity with your clinicals to be able to do some assessment, and you probably have seen how important that is. And with these patients, especially those in our intensive care unit or are on their way to the intensive care unit, you have to have good patient assessment skills. So for a VQ mismatch, remember, if I give you oxygen, I should increase your oxygenation. So what are we going to see with these patients? Well, one thing is we see dyspnea, tachycardia, tachypnea. Remember, the first sign of hypoxemia now and forever is tachycardia. The second one's going to be tachypnea because you're breathing faster to try to bring more oxygen on board. We see lots of use of accessory muscles. Nasal flaring is interesting. We see that with babies who have problems. It's really kind of shocking, I guess, in some cases, to see it with an adult because we don't think adults can have nasal flaring. Cyanosis, of course, because of that decrease in oxygen. The late stage is your CNS dysfunction. These guys have altered levels of consciousness. They also have some of that like blackout. They're living in a tunnel. Something along that line is happening at that particular point. And if they're really hypoxic, or hypoxemic, they're really, really restless. So we really have to keep an eye on them, okay? When we listen to them, for the most part, we're going to have some wheezing. We're going to see some diminished breath sounds. We have unilateral abnormalities that go with it. You can have some crackles and things like that. And depending on what the underlying cause is, that x-ray is either going to be black or white. Okay? Your shunt, though, on the other hand, remember, I can give you all the oxygen in the world. The problem is that you're not going to get better. And so what are some of the possible causes of this? Your pathological anatomic shunts, okay? You can have your AV malformations. You can have other things going on at this particular point. Collapsed airways. We can have fluid or exudate filled airways. What are we going to see when we assess these patients? We're going to see the same thing we see with the VQ mismatch, however, in some cases worse. And in some cases, depending on how bad it is, we may even lose some of those breath sounds at that point. The other thing is most part with the x-rays, we're going to see those x-rays getting wider and wider. And the reason we are is because of all the exudate that's sitting now in those alveoli, okay? So here we're going to start taking a look at our formulas. And here's one that you guys have seen since the beginning of your program, and it's called the alveolar air equation. In this one, we're trying to determine how much oxygen is available in the alveoli for diffusion across the AC membrane into the arterial blood. And remember, this is your P big AO2. It's equal to whatever the barometric pressure is, minus 47, times the FiO2, minus PaCO2 times 1.25. And remember to follow the rules of the road, okay? Parentheses, multiplication, division, then addition and subtraction. What you see on the next one is the reciprocal of the PaCO2 times 1.25 is actually PaCO2 divided by 0.8. And if you remember, that 0.8 is the respiratory quotient, which is affected by our diet. We talked about that in advanced patient assessment. A lot of times what you'll see on quizzes or tests or things along that line is we use a CO2 per minute production of 200 mLs divided by the use of oxygen per minute, which is a VO2, V.O2, which is 250 mLs. When you divide 200 by 250, the answer comes out at 0.8. So that's your respiratory quotient, okay? Okay, so here's your used to be called the A to A gradient. You may still hear that, but you're also going to see the A to A difference. And remember what this basically is the difference between the oxygen available in the alveoli and the oxygen that diffused into the arteriole. And the difference is what we're looking at this particular point. If you remember in first semester, they used to say it's either 5 to 10 millimeters of mercury. If you remember that, everything will be fine. What I'm going to tell you is this is age-based. And the older you are, the less diffusion you get. And if you can see here, the norm is somewhere between 10 to 25 millimeters of mercury, dependent upon the age. On 100% oxygen, it's 25 to 65 millimeters of mercury on 100% oxygen, okay? And that's also age-based. And it's, like I said, it's either called the A to A gradient or the A to A difference. If you notice up there, it has a big A, little a, DO2. That's the alveolar arterial difference of oxygen. Every now and then you'll see that either on your board exams or you may see it in the literature. Most commonly, though, you're going to see more of the P in parens, big A minus little AO2, okay? So just be aware that you can see either of those. Can you estimate what it is? And this is a good one for you guys to figure out. Take your age divided by 4 and then add 4 to it. So if you're 100 years old, 100 divided by 4 is 25, and 25 plus 4 is 29. If you went ahead and worked out your math on a patient on room air, and the difference was 28, 29, that patient is normal for that age. Now, there's different formulas that you're going to see on how do we estimate shunts, okay? This is one that wasn't Egan's at one time. There's actually a new one with Egan's. I'll tell you what it is here shortly. But you can take your A to A difference or A to A gradient as long as the patient's on 100% oxygen and do an estimated shunt, okay? On this particular formula, you just take that difference, divide it by 50, whatever the answer is, multiply by 2, and that gives you the shunt, okay, or approximate shunt. And the example here is saying your P big AO2 is 350, your P little AO2 is 80, the difference is 270 divided by 50. There's a 5.4 difference times 2. Your shunt's right around 11%. In Gary Persing's, he has a different shunt formula. Take a look at that. They're fairly close that way. Matter of fact, I think one of the things that he does, instead of using 50, he uses 20. So it would be 270 divided by 20, and you come up with like a 13.5% shunt. But just be aware there's different formulas out there, and it's just a matter of working them at that particular point. Now, to add to your list of what puts you on and what takes you off ventilation or support, if your A to A gradient or A to A difference is greater than 350 millimeters of mercury on 100% oxygen, your patient is a candidate for support. If the A to A difference is greater than 350 millimeters of mercury on 100% oxygen, you are a candidate for support. In order to be weaned, the A to A difference has to be less than 350 on 100% oxygen. So add that to your list of what puts you on support, what takes you off of support. So another thing we can look at is the A to A ratio, the little a to big A ratio. And this is your P little AO2 divided by your P big AO2. And as you can see, I'm going to show you here, and then we're going to go back and talk about it. It's a little more stable than the A difference or A to A gradient with your changing levels of FiO2. It's still a good formula. However, it too has different problems that people still talk about. You know, this is all really sometimes a guess as to what's going on with these patients. Okay, so anyways, on this one, your little a to big A will tell you the norm is 0.7 to 0.9. This is age dependent. When you look in the literature, you're going to see that the literature uses 0.74 to 0.9. It doesn't normally record as 74% to 90%. A VQ mismatch is less than or equal to 0.60 or 0.6. And a shunt is anything less than or equal to 0.15. And when you have a shunt that's less than 0.15, this is a severe shunt that's refractory to oxygen. And if you remember, the word refractory means non-responsive, okay? So this is non-responsive to oxygen. Now the question comes up, well then what goes on between 0.60 and or 0.61 and 0.74? Well, the answer is your patient is still considered somewhat normal. A lot of it also has to do with aging as well. So we really don't count as a VQ mismatch until we get to that 0.60. So if anybody asks you, it's normal. However, if it's going down, we're headed towards that VQ mismatch, okay? So that's the best way to go ahead and deal with that. And here's the fun part. This is the classic shunt equation. Problem we have with this is that it's hard now to get the venous side of the house. We're not putting in as many pulmonary artery catheters as we used to. Part of it has to do with infection. Whenever you put a hole in the body, you're opening a route for infection. However, there are still cases where we are going to do this. And as long as the patient's on 100% oxygen, then we can use this formula to tell us, you know, what's going on with these patients. It's a really good indicator of a shunt and what's going on. The formula is your QSQT, the amount of blood being shunted versus the total amount of blood being put out. The formula is your CCO2 minus CaO2 divided by CCO2 minus CvO2. CCO2 is the O2 content of alveolar capillary blood. This is what's available in the alveoli. It's always 100% saturated, okay? Your CaO2 is the O2 content of arterial blood. And you probably had to do this if you had an ABG when you got your case study, okay? And then the CvO2 is the O2 content of the true mixed venous blood. And you have to have either the pulmonary artery catheter, known as the Swan scans, really in order to be able to get this done. And you can express it either as milliliters of O2 per 100 milliliter blood or vol percent. That's your shorthand. Really, really easy, okay? So the formula, regardless of what you have, is 1.34 times hemoglobin times either S big AO2, S little AO2, or SVO2 plus P big AO2, P little AO2, or PVO2 times 0.003. That little x, as you can see there, means big A, little a, or venous. All right, so the formula for CCO2, 1.34 times hemoglobin. You can either use 1, because I told you that any oxygen in the alveoli is already at 100% saturation, and anything times 1 is still itself, or you can just leave it out, whatever you're comfortable with. plus your P big AO2 times 0.003. C little AO2, the O2 content of arterial blood, your formula is 1.34 times hemoglobin times S little AO2. Remember, you're going to get that when you do your ABG to get your P little AO2 that you're going to multiply by 0.003. And then the CVO2 is the O2 content of mixed venous blood. Your formula is 1.34 times hemoglobin times SVO2 plus PVO2 times 0.003. Remember that venous sample comes from the pulmonary artery, either with the pulmonary artery catheter or the Swan scans, whatever they're talking about at that particular point. Remember, too, your patient has to be on 100% oxygen. So grab your pencils, because indicator for support, a QS-QT greater than 15 to 20%. Indicator for support, QS-QT greater than 15 to 20%. Weaning, a QS-QT less than 15 to 20%. So, what does all of this mean for the most part? Normal human being, we already know you got about a 5% shunt that you live with, okay? However, with this, now what we're looking at is the norm being right around the physiological shunt, less than 10%. So as long as it's less than 10%, we're not too concerned. A mild shunt is anywhere from 10 to 20%. Significant, 20 to 30%. And anything that's greater than 30% is critical and severe. Okay? 100% oxygen, and that's going to tell you what's going on there. So there's actually some modified shunt equations that we're using now. You may or may not see these. However, they do exist and they are used. So basically what we do is, as long as your patient has normal lungs, we're going to do the CCO2 minus CaO2 divided by CCO2 minus CaO2 plus 5. The normal difference between CaO2 and CVO2 is 5%. So make sure you write that down. That's a pretty cool formula. The normal difference between CaO2 and CVO2 is 5%. In the critically ill patient, we're going to use a different number because the lung function is not as good as it is in a normal patient. And in this case, it's going to be CCO2 minus CaO2 divided by CCO2 minus CaO2 plus 3.5. Okay? So if anybody were ever to say to you, oh my gosh, we can't get that venous blood, what are we going to do? What are we going to do? Well, take a look at that patient. If they're still pretty normal, you know how to do it. If they're really critically ill, you have that also. So you have 3 slides coming up here. These are part of your homework that you're going to submit.